Okay, good evening, everyone. I know people are still joining, but we'll start on time because even Mansi has, come here and she is here with us in spite of having a very busy schedule. So we'll start on time now. Warm welcome to all the attendees joining us for this special webinar, which is, as we are observing Diabetic Eye Disease Awareness Month. So today's webinar it will focus on exciting and rapidly advancing area in eye care, which is multimodal imaging in diabetic retinopathy, OCT, fundus photography, and some AI tools. So we all know that with diabetes on the rise globally, the need for accurate and efficient and accessible screening methods has never been more critical. Multimodal, imaging has transformed the way clinicians detect, classify, and monitor diabetic retinopathy. So we are honored to have Ms. Nancy Mahalingam, who will guide us through the latest advancements and clinical applications. I'll quickly introduce her. Ms. Mansi, she is an optometrist and researcher from India, specializing in the cutting edge field of multimodal imaging of retina and glaucoma, image analysis, and low vision. She is currently pursuing her doctorate at the University of Western Australia. Her academic journey includes the attainment of bachelor's and master's degree in optometry from the esteemed Elite School of Optometry, Chennai. She is a fellow of American Academy of Optometry. After her post-graduation, she became a part of a reputed institution, Arvind Eye Hospital, where she served as a clinical and research optometrist and was in charge of ocular diagnostics in the retina department. She also mentored optometry fellowship students and collaborated with ophthalmologists to publish research papers. Welcome, Mansi. Over to you now.
Thank you, Harshada. Thank you for the invitation and the introduction. I'll quickly share my slides. Let me know if that's okay. Are you able to see my screen now?
Yes, yes. Yeah, we can see your slides.
Okay. All good. So good evening, everyone. Thank you for joining on a Friday evening. So today I'm going to talk on the topic multimodal imaging of diabetic retinopathy, OCT, fundus photography, and AI tools. How to integrate the modern imaging tools for effective diabetic eye exams. Um, Before I begin, just a second. Yep. So a quick disclaimer, I'm going to approach this topic as from the clinical perspective as an optometrist, but not as an AI or a computer science expert, which I neither am I. So I'm going to focus mainly on the patient care and the practical clinical applications. And also, I'm not practicing at India at the moment, so it's going to be the review of the existing literature. Um, so I don't know how many of you have watched The Friends, where Ross Geller says that by the year 2030, there will be computers that can carry out the same amount of functions as an actual human brain. And he has predicted it really correct because we are towards 2030 and we can see the advent of AI in vision science, especially. When I was given this topic, this picture immediately came in my mind, thinking about the available knowledge on the artificial intelligence in ophthalmology and especially diabetic retinopathy. But I'm just going to cover just a drop of it. Um, so also, I'll be having some polls in my slides. So I would ask you to use your Chrome at the moment or any at the times I got the poll. Um, so why do we celebrate World Diabetes Day? So why it's not just the national disease? So we celebrate the World Diabetes Day because it's not just for the healthcare practitioners to be aware of, but also the general public to be aware of this critical global public health issue. I got this picture from the International Diabetes Federation, and they have classified India among the Southeast Asia. And it was really shocking for me to see the amount of increase predicted for the year 2050, which is going to be 73% increase in the people among people in this country for the diabetes. So now I would ask you guys to open your Chrome and then type this in your mentimeter.com. Can you see my slides now?
Yes, we can see it.
Yes. You can just open your any browser or even your Google and type menti.com. and you can type in the code, which is 74277745. And also let me know if you have any issues with this. Very good. So the question is, how many people do you think are currently living with diabetic retinopathy in India? Is it 95 million, or is it 101 million, or 105 million? You can take your guess. There is no right or wrong answer, so you can give whatever you feel. That's good. I'll wait for 3 more responses and then I'll jump into my presentation. Okay. Okay. So the correct answer is about 1.4 billion people in India. About 101 million is being affected by diabetic retinopathy. And also we can see that the graph on the right is actually showing the number of people with diabetes, which is going to rapidly increase by the year 2050. And it is also it is also shocking to see that India is the diabetes capital of the world. So we should be really working on this. Okay, instead of talking that diabetic retinopathy is the leading cause of avoidable blindness and all those things, but I wanted to look at the behind the scenes of what's actually causing this burden of diabetic retinopathy in India. So it could be there are so many reasons, but main reasons are going to be the lack of healthcare professionals and lack of awareness among the regular eye exams and the poor screening coverage. Not everyone in the rural areas are accessible to the eye care, and also the treatment barriers and the cost barriers. If any ophthalmologist suggests anti-VEGF injections for the people with diabetic retinopathy, not everyone is going to accept that mainly because of the financial constraints. So I just have a very simple, quick scenario. This is not an exact clinical case because I don't have any cases at the moment. Let's say a 62-year-old man with uncontrolled type 2 diabetes visits an optometrist only because he cannot see the bus numbers clearly. So with this kind of persons, so they will either go to the independent eye care clinics or they will go to the tertiary eye care hospitals. So the first point of contact is going to be the optometrist. So if this kind of person is going to meet optometrists like us, so the optometrist will notice a drop in the vision, and if they have the available facilities like the OCT angiography and fundus photography, we will do all those things, and then we refer to the ophthalmologist immediately based on the signs and symptoms. So the role of optometrist is really important as we are the first point of contact where we can also do the comprehensive eye examination and some available retinal imaging if they have their independent clinics, and also providing them the follow-up and the patient education, and also collaborating with ophthalmologists accordingly. I was also thinking of other stations where we can also pick up the diabetic retinopathy. Instead of the independent optometry clinics, we also have the diabetic specialist clinics, outreach camps, which is mainly aimed at diabetic retinopathy, vision centers, and teleophthalmology. So all these places are really very helpful in picking up the diabetic retinopathy in India. So moving on to the actual topic. So today I'm going to talk about the traditional imaging in diabetic retinopathy. So the first one is going to be the fundus photography and then the OCT and OCT angiography. I don't know how many optometrists have the leniency to do the fundus angiographies, fundus fluorescent angiography. So I thought myself to stick with the first 3 modalities. Also, before I move on, I would like to introduce about AI. As I said, I'm not a computer scientist, so I'm going to explain whatever I understood. So AI is nothing but a human teaching the computer or the machine to mimic himself, like a mom is teaching the kid. Again, it's a huge part of the science where we got the machine learning and deep learning models set to work for the vision science. So machine learning is where it requires human experts to manually define the relevant features from the data before the algorithm can learn. For example, I got a picture over here. In the top picture, we can see how a machine learning works. If you have a cat, we can see the human icon over there. The man has to explain the features of the cat. Say, if I'm going to send you a picture, and if it has got a head, a body, and a tail, you should classify it as cat. If it doesn't have those features, you should classify as not cat. So that's how the machine learning works. We have to give the features to it. Whereas deep learning is a subset of machine learning where we don't give any features extraction. It just learns on its own with the data sets we provide, and then it itself gives us cat and not cat. So this is the main difference between the machine learning and deep learning. In the deep learning, as the name suggests, it has multi-layered network to automatically learn from itself and extracts complex features from the raw data. So this is how a simple deep learning pipeline in ophthalmology looks like. If you just give a feed in and input image, which is, let's say for a fundus example, fundus photography, it does the features maps, which is the features extraction and the classification on its own because it's deep learning. And it's going to spit out whether it's going to be a referable DR or non-referable DR. So this is the very, very basic outflow of how the AI works in vision science. Also, in order to test an AI model, if anyone comes and asks you, well, is this AI model good or not? We have to look at those accuracy metrics. I'm not sure if everyone knows it, so I thought to explain it in a bit. So we have to look at two values. One is going to be the sensitivity, and next is the specificity. So sensitivity is, it measures a test ability to correctly identify those with the disease. It's called the true positives. Whereas specificity, it should identify those without the disease. Because there is no point in treating the people if they don't have the disease, right? So both these values should be of reasonable cutoff, and if in order to be an AI model to be promising. So moving on to the fundus photography, these are the clinical signs. So I think you'll be much familiar than me. So the features of the non-proliferative diabetic retinopathy, it's going to be few microaneurysms and retinal hemorrhages and hard exudates in the milder form. In the moderate form, it's going to be the same set of signs, but with increased number, but added to it is the dot and blot hemorrhages and the cottonwool spots. Whereas in the severe NPDR, there is going to be severe hemorrhages in 4 quadrants, venous bleeding, and moderate intraretinal microvascular abnormalities in 1 or more quadrants. The severe form of diabetic retinopathy is going to be proliferative diabetic retinopathy, where you'll be seeing the neovascularization in the disc and neovascularization elsewhere. So in order to integrate the AI and fundus photography, you won't believe there were so many papers and so many models available all over the world in different countries where they have tried all these methods to see how it works. So this is a quick example of fundus photography, especially with diabetic retinopathy. Processing all the deep convolutional neural network, and then it's just says whether it's going to be non-referable or referable DR. So on the right side, I got so if it is going to be mild and there is no problem, it's going to be non-referable, whereas all the others are going to be referable diabetic retinopathy. So one of the first FDA approved fundus photography AI model is going to be the IDR-DX, so which is also called as Luminet X4. You can have a look how it works. So it comes along with the TopCon OCT, where you will have to just take the picture of both the eyes. So once you have taken it, you can click the images, and once you click it, it's going to show the result as negative. So the patient doesn't have diabetic retinopathy. The same way, there are 3 additional systems cleared by the FDA, which is iArt and Retinal AI Galaxy. You can have a look once this is over. So looking at the IDR-DX alone, so I found a systematic review where they just looked at the sensitivity and specificity of the same IDR-DX all over the world. And it's very good to see that the sensitivity and specificity values are about 85 to 95%, which is really promising. And the same way for the other countries as well. So this specific paper has combined all the sensitivity and specificity, thereby to create a pooled sensitivity values, which we stated in the slide. It's about 95% and 91 specificity respectively, which is really promising for the AI model. Another interesting model is the Google's deep learning algorithm. And I chose this paper because Google collaborated with three tertiary eye care hospitals in India. One is Shankar Nethralaya, Aravind Eye Care System, and Narayana Nethralaya. And also it's very good to see the promising results again, the sensitivity values of 90 and 87. So they tried in different data sets and then they got very good results. Moving on to the OCT. So OCT is going to be the high resolution of structural information of retina. On the left, I got the clinical signs of the mild diabetic retinopathy, which is going to be the microaneurysms, again the dot and blot hemorrhages, cottonwool spots, and then the hard exudates. Whereas in the right side, we got the severe forms of diabetic retinopathy, where we will be seeing some neovascularization. Sometimes we also get to see the pre-retinal or the vitreous hemorrhage and the traction retinal detachment sometimes. So the AI and OCT models were also available. So this works on the deep learning model, where I also came across the term called the transfer learning, which means they take the model which is already trained and then do some modifications according to what they wanted, and then they expect the values. It's like similar to the way we get a house. Instead of buying a new house, we are taking an old house and modifying it according to our needs. The same way, in this, they are introducing the ROI location, which is nothing but the region of interest. So they define each radius and then they extract the features and then they ask the model to classify it as whether it has got the DMD, or I think this model worked with drusen as well. So it's like a multiple ocular diseases, and they try to see how it works. And fortunately, it worked with the specificity of sensitivity of 99% and specificity of 98%, which is very promising for the OCT. Moving on to the OCTA and diabetic retinopathy. So in OCT angiography, there are again four groups of vasculature seen in the angiography. So, but for the interest of diabetic retinopathy, we are just going to look at two. One is the superficial and the deep retinal layers. And the main feature which is going to affect in diabetic retinopathy is going to be the FAS area, which is the foveal avascular zone. As I shown the picture in the left corner of the slide. So as the severity of the diabetic retinopathy increases, the FAZ area is also going to increase. The vessel density is also being reduced with the severity of the diabetic retinopathy. And we also can get to see the microaneurysms and IRMA in the OCT angiography. The same way, the transfer learning was available for applied for the OCT angiography. As I said, again, the transfer learning by Lee et al. So we can see the sensitivity and specificity and accuracy values. One interesting fact is that this team created a graphical user interface, which is similar to an application. As you can see in the slide, if you just if you just give the OCTA as an input, it shows it's normal or it's abnormal. And then from there, we can proceed to referring them to the ophthalmologist. So again, there are so many models available with OCTA and deep learning models available all over the world. Okay, now it's the task time again. You can take your Mentimeter.
Manasi, sorry to interrupt. You can just write the code, in the chat
Okay.
box so that, yeah.
I think it's
Those who
going to
have
be.
joined recently, please,
Oh,
yeah,
okay.
because there are a few people who have just joined. So
Okay.
you can log in on you
Yes.
can go on to menti.com and insert this code, and then you can answer the poll.
Yes. Okay, I'm just gonna wait for 2-3 minutes for everyone to give an answer. So those the ones in the right are just the example keywords. It's not that you should choose the same. You can choose whatever you want. Yeah, you can type in whatever you feel because we are not going to develop an AI model from this. So you're just free to feel free to type in and we can. Mm-hmm. Okay. Mm-hmm. Perfect. Let's go back. Thank you for your responses. Let me keep going. So, to give a summary, there are so many models available, but we have to choose the suitable situations as shown in this picture. So, even I got this picture from one of the review papers. So, we should choose the situation and then see if the AI model is going to be really applicable, and then we can go ahead and proceeding with that. Do you still think that there's a need for AI in for the diabetic retinopathy screening in India? I feel yes, because it's going to be due to the population growth and the aging. Number of patients with diabetic retinopathy is going to rapidly increase by 2050, and also the ratio of ophthalmologists to the population is in India is very less. It's 1:65,000, thereby making the resources not available for everyone who deserve eye care, and also the demand for more ophthalmic personnel to treat the patients is critical. But however, we cannot meet this need because it's going to be practically unfeasible. So thereby, the role of AI model comes into play where it helps us in screening remote areas, especially via teleophthalmology, and it still helps to tackle medical resource shortage and health inequities, thereby improving the screening coverage. Yes, however, there are two sides of the coin. The other side of the coin is going to be the challenges. So, not every rural area will be sufficed with the access to technology or a good internet connection. And also, we need high quality standardized retinal images for testing. So, but that's not going to be the case in the real data, right? So, we may not get high quality images. So it's really important for us to look at the data which we are just giving as an input to train the data. So it's like garbage in, garbage out if you don't have a clear data and if you don't have the clear outcome you want from the model. So, and also still some clinicians, like some ophthalmologists and optometrists, see AI as a black box, hard, not sure of what's going on inside. So it's still making it unsure to understand and trust it. And also the main thing is that the regulatory approval, which is the FDA, it's going to be expensive and sometimes slow. So yes, I've come to the end of my presentation. So the eye is the window of our general health, but I know there is a quote saying that eye is the window of our soul, but I just modified it for the general health. So diabetic retinopathy is one of those conditions which can be picked only with the signs in the eye. So, but still, AI can enhance the diabetic screening by improving the efficiency and coverage, but it is not going to be the replacement for human judgment. However, if we both join the hands together, like healthcare professionals and the deep learning models or the AI tools, it's definitely going to help in picking up the diabetic retinopathy soon, the early identification, and thereby improving the diagnosis. So I would recommend each and everyone in the session, and all not only the optometrist and all the ophthalmic personals should encourage the people around them, especially their families and parents, to get their eye checked, like especially the regular eye exams at least once a year if they are above 40. Thank you, and I'm open to discussion.
Thank you so much, Mansi. Thank you for your talk. And today's session, it has reminded us that DR is not only a growing concern, but it also a condition, which where the timely imaging and evidence-based evaluation can make a profound difference in preventing vision loss. So thank you so much for your talk. If participants have any questions, they can put them in the chat box. Meanwhile, I want to ask you, Mansi, that any thoughts on those smartphone-based retinal imaging, which has come up now, and people can even the optometrist, they are user friendly, and you can carry it anywhere. So, any thoughts on the reliability or the accuracy of those on that smartphone-based retinal imaging?
Yeah, thank you for the question. I was about to talk and then I completely forgot about it. So, I had a privilege to work with the Remedio funders on phone.
Uh, Mansi, you there?
Accurate, the metrics are very good for the in case of accuracy. I can also share the paper which we got recently.
Mansi, sorry, we lost you in between. I think your voice was
Oh,
not clear. Yeah. Could you please repeat the answer? Yeah.
can you hear me now?
Yeah. Perfectly fine. Yes.
Yes. So yes, I was collaborating with Remedio funders on phone, where I was involved in the data collection for the training set and the validating the. But it's for the AMD. I've not read about the diabetic retinopathy. But I was just looking at it, and then, but the accuracy is really, really good for again. And as an optometrist, I felt it's very easy to handle it because I was collecting the data in the clinic. But I also heard I was asking some of the people in Aravind High System where they have vision centers and they even still take the FOP over there and they still use it for the teleophthalmology. So it's really helpful in these days. Yes.
Okay. That's great. Okay, we have one question. Any model AI for fundus imaging to detect NPDR for free as in for free application?
Uh,
Uh,
Yeah, thank you, Mr. Shanmuga Kumar. I'm not really sure how to access these models. Like, I totally get like to for the free applications, but I think if you have like if you have like your independent clinic, I think we can approach. Example, the only company which I'm getting reminded is Remedio because I got a chance to work with them. We can try contacting them to see how it works because I'm not sure of the uh, way to actually purchase or how to get use them. But yes, try contacting them, the team directly, so that we can get to know because we may not sure right if they are available to give some free options or I'm not really sure, so I couldn't answer it.
okay. Okay, there's another question
Can we
from
obtain accurate biomarkers in smartphone-based retinal imaging in case of AMD? Hi, Kritika. I'm not really sure of the accurate biomarkers because, again, I think it's the accuracy still comes with the specificity and sensitivity, but I'm not sure if it depends on the outcome, what you want and what they have tested on. So, for example, if you're looking for the CNVM as a criteria for your cases, but while they're testing if they don't have that in their outcome it's not going to pick up not going to pick up that biomarker. So again, I have to look at the but I can get back to you when looking at the AMD and the smartphone based retinal imaging. Yes. How many cost? No, I'm not really sure. No. Yes. Any other questions? Because I'm not related to any institute where they sell the applications, where they sell the AI models. So that's why I couldn't answer the financial side of the AI models. Um, student, thank you. You currently person. Oh, yeah, my student life is Harshada would be so familiar. My student life is, yeah, I'm enjoying it, but it's a bit stressful at the moment, but I'm enjoying it, yes, because this is what I wanted. So, yeah,
yeah.
thank you. Okay, yeah.
Thank you, Mansi. Any other questions?
I can share this. I can share my contact details. So, give
Yeah,
me a second.
that would
Sorry.
be really great. Yes. Yeah.
Mm-hmm. Yes, you can contact me anytime. Not only just to for the AI if you wanted to do. PhD in Australia as an optometrist, or if you wanted to approach for any other professional or any doubts, you can contact me. Yes.
Yes, Mansi, just last question, just for the students who have joined us. So, what would be the ideal imaging protocol for the first time diabetic patients? A lot of time, we practitioners tend to do everything, when patient comes and they say they are diabetic. So, what would be the ideal imaging protocol, those who are visiting for the first time?
Yeah, as far as my experience, I think we'll first do the OCT because we can exactly know the signs if that's the only thing there which is available. Because I think not many can have the fundus photography, but rather than they still have the OCT because OCT can we can see the structure information. I think most of the clinics will have OCT, not just for diabetic retinopathy. It can be used like for all the retinal diseases. So if they got the fundus photography, they can still go and do the fundus photo next. But I would recommend doing the OCT first to know the exact. So mainly we do OCT to know about the macular status because if the macular is edematous, it's definitely not the early stages of diabetic retinopathy. It's going to be sometimes the clinically significant macular edema. So I think OCT is first, and then if they, it's not like fundus photography is mandatory. If they got it, it's better to document because it's sometimes I use fundus photography to explain them. Look at this. It is good. This is how your back of your eye looks like, and there is some dot and blot hemorrhages. But I'm not going to tell dot and blot hemorrhages. I'll explain them. There is blood clot, and it's because of your diabetes. So it's really has created some impact. I still remember some stories where I did this, and it's really impactful.
Yeah.
So go with OCT and be thorough with your OCT signs to see what to look at exactly at those layers. And yeah, if they have the availability of OCT angiography, that's the next step. But yeah,
Okay, any other questions from the participants? Yeah, there are
thank
some
you,
lovely.
Shweta. Thank you.
Okay.
Yes, I'll just my email. I'll just share my
I
contact
put it in the chat
details.
box, so if anyone wants to connect it with you, they can. Yeah, see, that's why we wanted you only to take this session.
Oh my
I
God.
know you were very busy.
Thank you. Yeah, I love working with Retina, but I wanted to widen the scope, so I just jumped into glaucoma. But I hope to be back in Retina very soon. Yeah. Yes.
All right, so no more questions. We can close this session now. So thank you all for joining for today's special Diabetic Eye Disease Awareness Month webinar. And a special thanks to our speaker, Ms. Mansi, for sharing such valuable insights, clinical pearls, and real-world applications of the multimodal imaging. So thank you so much for joining us today in spite of your busy schedule. We hope this webinar has inspired participants to adopt these, advances in your clinical workflow and to continue raising awareness about the importance of regular eye examination for people living with the diabetes. So thank you everyone once again for your active participation and have a wonderful day ahead. Thank you.
Thank you,
Thank
everyone. Thank you. Have a great evening. Bye.